Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
All right, Spelunkers, my guest today is Dr. Soyoung Lee. Dr. Lee is a PMN&R physician who is also a PhD. Her PhD was in cognitive neuropharmacology. She currently is enrolled in the master's program of prosthetics and orthotics at Northwestern University. She is truly a lifelong learner, and I have enjoyed all my previous interactions with her tremendously, as she's able to give a perspective that we sometimes don't see in just our specialty. So without any further introduction, please enjoy this conversation that I have with Dr. Soyoung Lee. All right. Well, I'm here with Dr. Soyoung Lee, who is a very fascinating colleague, and I'm very happy to have her on the show today because I haven't really had a chance to visit with her probably in more than 10 years. And she had been so kind to take some time and visit us a while back in the clinic, and we shared some great interest. And I think the audience will enjoy this very much. So thanks for coming on the show, Dr. Lee.
My name is Soyoung Lee. I'm a physical medicine rehabilitation physician, and I am a student at Northwestern University in Chicago.
And when did you start the program at Northwestern?
And I am studying the prosthetics and orthotics master program.
And when did you start?
I started last year, and this is my second year, and I will graduate on 2025.
Okay, very good. And prior to that, why don't you tell everybody about your experience in medicine and rehabilitation in South Korea before you even started looking into what we're doing in podiatric medicine here in the United States?
Okay. I majored in Gamil University, Daegu, South Korea, in the medicine. And then took a residency in physical medicine rehabilitation for 4 years at Dongsan Medical Center. Also, it is in Daegu, South Korea. And I have earned the PhD in the cognitive pharmacology from the Gyeongbuk National University. And then I devoted to my field as a physiatrist, PMN&R physician, to see the patients at the time. I was very interested in the field as podiatric medicine. Mm-hmm. And especially in 2010, I was exchange professor at MD Anderson Cancer Center and Baylor University at PMN&R department. At the time, I have an opportunity to visit many clinics, podiatry clinics. And I found this is the thing I really wanted to learn and to do for my patients, because there are so many foot and ankle patients in Korea. So that's why I try to study and do practice in my clinic in South Korea.
Now, what is the predominant foot and ankle problems that you see in Korea that evidently really weren't being treated as much or with this focused approach that you're now trying to develop in your personal expertise. What was it like before you discovered some of the things in podiatry, and why did you want to look at podiatry? Was there something missing for you there?
Oh, yeah, that is very good question for me, because before I know the podiatry medicine, everything about the foot and ankle problem is if you have a problem at foot, we will do injection or we will prescribe. Prescribe the pills not to feel the pain, and we focused all the way to the results. But when I know the podiatry, I would like to try to figure out what makes them feel the pain, especially in the adults. And then at that time, I thought that what is the connection with the podiatry medicine and the pediatric patients? And then I found the foot problem will continuously affect the development of my pediatric patients. If they have some deformity or some malalignment problems, they will not attain their normality. And then the second one, I would like to diagnose the factor what makes my patients delay development. For most of the genetic problems is diagnosed far from when they have the symptoms.
Okay.
Just in case, there is male patients. They are brother and younger brother. They are two boys, and they came to my clinic, and their foot have some case planus, but it is far different from the usual range of the past planus. I found that they have some problem on their muscle, and they have Duchenne muscular dystrophy.
Okay.
And the other case have the limb girdle muscular dystrophy. My third case was Charcot-Marie-Tooth disease.
Okay.
And this case is, if I do not know the podiatric medicine, I cannot diagnose what their problems.
Right. So let me ask you a question. Let me ask you a question before you go on, because you brought up Charcot-Marie-Tooth disease, and you may not know the answer to this, and I don't know the answer to this question, and that's why I'm asking you. But it seems like in Charcot-Marie-Tooth disease, there is a preferential nerve entrapment or nerve affectation of the common peroneal nerve versus the tibial nerve. You'll note that they have usually very good strength in the posterior calf, but their ability to dorsiflex is always usually more prominent compared to their posterior calf musculature. You have any idea of why that would be?
Not necessarily, not exactly. I don't know, but definitely there was some this malalignment very early.
Okay, but
so I think.
But do you see that as like we see that there is a preferential predilection that the common peroneal nerve seems to be much more affected in these patients than the tibial? Do you see that?
Yes, right.
Right.
And common peroneal, you know that common peroneal nerve is innervated the frontal and lateral structures of the lower extremity, right?
Right.
And the posterior tibial nerve, will innervate the most of the big and strong posterior structures, gastrocnemius and the soleus, right?
Right.
And I thought that there is pretty much opportunity to use the posterior structures than the anterior structures, because the range of motion of dorsiflexion is just 20 degrees, and the range of motion of the eversion is just 20 degree. But inversion and plantar flexion is the range of motion is more than that frontal and lateral muscles.
So you're saying then that I'm trying to get what happened. Is it the chicken or the egg? Is it that because the amount of range of motion for plantar flexion, which is all posterior calf,
yes.
Is it, you think that has some reason, the differences in the range of motion between plantar flexion and inversion and dorsiflexion eversion being a much smaller range of motion? Do you think that has something to do with the preponderance of the nerve entrapment, or the nerve affected seems to be more the common peroneal nerve rather than the tibial? Is that what I'm hearing, or am I misunderstanding?
It is not just for the range of motions. For that range of motion, I think the muscle is more ability to move. And the other thing is common peroneal nerves. If you see the cadaver study, the nerve is very thin, and the nerve have to pierce the intermuscular septum sometimes. Mm-hmm. So I think there is some reason on there, and there is some contractures on the Achilles tendon, you know that?
Right.
Yeah. Is there any opportunity to contraction of those flexor of lateral peroneus longus and brevis?
I'm not sure. I think I understand what you're saying, and let me clarify this. So we know that the common peroneal nerve, because anatomical, the way it courses, the way it has to course through some of these intermuscular septa, it just that just makes it more likely for it to become trapped than, say, a nerve like the tibial nerve, because it doesn't have the same. It's kind of like a road with many curves versus a straight highway. The straight highway, you can drive the car very fast. The curvy road, you cannot drive as fast. You think so? It's an anatomical predisposition that in Charcot-Marie-Tooth.
And I'm begging your pardon?
Well, I guess what I'm trying to understand is that when I see all these patients with Charcot-Marie-Tooth disease, it's almost like they have perfect muscular function in the posterior compartment of the calf, whereas they have tremendous amounts of impairment in the anterior and lateral compartments of the leg, lower leg. Mm-hmm. And it just seems very interesting that these folks can be very strong in one group, but very weak in the other. Do you understand what I'm saying there?
Yes, right. And there is an anatomical factor, and the other thing is, I think the alignment change, because if we have the pes planus foot deformities, in case of the Charcot-Marie-Tooth disease, you have already pronated, and you have already pronated foot, and there is no not spinated pronated foot, and you have already dorsiflexed, and your lateral musculature is already very close. It is changed, so there is no need to move more than before.
Okay. So almost like a disuse atrophy?
Disuse. And I think I would like to ask you back about what is the eggs, what is the chicken? Because pes plantar valgus deformity makes them more prone to nerve damage of the anterior common peroneal nerve, or the common peroneal nerve liability will make them more prone to. So if we would like to solve this problem, we have to diagnose them as soon as possible. After we diagnose them for 10 or 20 years later, we just figure out the results.
Right. Now,
And that's why
I think I think this is very interesting and very important because we've had discussions in the Nervous Society about these. A lot of times, the patient with Charcot-Marie-Tooth disease, if you can decompress their common peroneal nerve, their function improves, and it seems like the amount of orthopedic deformity is decreased over a period of time if you can get them early. And there's very little written about it. Very little in peer-reviewed literature about it. But I think it's a very interesting thing because if there is something that we can do like a nerve decompression, which is a very minimally invasive procedure, it may prevent these folks from not only having, a decrease in motor strength in the anterior and lateral compartments of the leg, but it also could potentially decrease some of the deformity that forms later on down the line. And that's why some of my colleagues and I have had some very interesting discussions about this, that there is a clear difference between the way these two main nerves in the leg respond to this particular disease.
I completely agree with your opinion. So that makes me think about I have to do diagnose as soon as possible if they have some disease, because we can trace their pathways, what make them to change their nerves. Because if you are doing decompression therapy, already there is some degeneration of the peroneal nerve. It is not working, right?
Right.
So in the near future, I'd like to follow up their nerves, peroneal nerves. Usually they can handle, and about if they have good cognition, they will stand the stimulation of nerve stimulation at 6. And usually if they do not well cooperate to the test, 10 or 11, it is enough to stand without some sedations. So I think I will follow up their peroneal and tibial nerve conduction and the integrity of their innervated muscles to figure out your good academic opinions.
Right. Well, I don't know that I'd even venture to say that that's an academic opinion. I think that's a bunch of guys having a cocktail after a nerve meeting that sat down and talk about these weird things that we observe, but yet there's so little published about it.
Mm-hmm. Usually the development and great mention is come out of the cocktail bus, right?
Yeah, I can't tell you how many surgical procedures I've developed on a cocktail napkin. And I will tell you that it's always easier to do that surgery on a cocktail napkin than in real life.
Okay, interesting, yeah.
So how many years were you in practice in PMN&R in South Korea before you started really getting into the foot and ankle and podiatric medicine? How many years did it take you to get this spark?
Actually speaking, my name is Soyoung, but my age is not so young. I was involved in my residency in 1994 and 1996. Yeah, it was 1996. And actually, my second grade in my residency, I was very interested in the podiatric medicine.
Okay.
And at that point, I have visited many clinics in South Korea, as many as possible, with some permission of my boss. And I exactly remember that time. And that time, there is no podiatry medicine in the South Korea. There is some physicians who just are interested in the foot and ankle, and they were made prescribe some foot orthotics. And I found one clinic. There was a patient. He prescribed by the doctor, and the foot orthotic is not good for him, and he was very upset. But the doctor did not change or did not prescribe the foot orthotics, because I think he didn't do that. Just the orthotist, the other room. Okay. There is an orthotist, who cast by himself and who did the orthotic. And at that point, I decided I have to do that all by myself. I have to do casting, and I would like to learn how to make them, and I would like to prescribe for my patients. Because if my patients are complaining what I did, I have to do it by myself, not to others.
Right. And so what you found was that if you just saw a patient that had a deformity that could have used or benefited from an orthotic, but you just referred that to the orthotist or the prosthetist or whoever is making those devices, that there was a disconnect between what you were seeing and what you wanted and what was ultimately made for the patient by the other person?
Yeah, at that time, they do not how to prescribe the orthotics, but they know that orthotics is introduced by some merchandising peoples. So they know that it is just it involves assumption. They know that it is working, but they do not know about the accommodation and do not know about the there is some people who do not handle like some accommodations. Correction is needed.
So what you're saying is that the orthotist didn't have a real expanded knowledge of biomechanics, and that impaired their ability to maybe make what you needed for your patients?
My patients?
Yes, your patients, if you had to send them out to someone else to make the orthotic, because that person who was making the orthotic, not you, didn't have enough biomechanical understanding or knowledge, that it probably might impair the way that they made the orthotic. Do you understand that question?
Yeah. First of all, there is pretty much orthotists who do not know about biomechanics and foot orthotics. Mm-hmm. So I had working with a total 3 or 4 orthotists at the time, and I teach them because I have continuously learning from the conference and from any academic societies how to prescribe them. And then I tested them 3 times, 4 times. If it is not working to my patients, I will reorder them. Okay. And then they have set some levels. And then I started to open my foot clinic. And before then, I have to teach them. Even though I have not educated by that kind of education, I have to teach them.
Right. And were they able to get you what you needed to have done after you taught them?
Yes. Okay. Yes. But it is not to other orthotists that do not make the orthotics like them. There are a few orthotists in Korea. So that's one of the problem. I think there have to be some organization for the orthotist. That's why I am here as a physician And that's why I decided to be a student again at NewPop, Northwestern University.
I think based on your curriculum vitae, that you will be a student the rest of your life. That you love, it seems that you love to learn and are a lifelong learner. And when you combine that with what you are seeing in your clinics with your patients, and then when you make a good observation that somebody doesn't necessarily have an answer for you, you go out and find that answer.
Yeah, exactly what I'm feeling when I involve this class. Yeah, they always told me that you already know this, but I know that there is something I missed, and there is something which is developed than before. So that's why I'm here to learn. And to do that, I have to, this much feeling in my cup, I have to throw them up and try to refill my cup with the new knowledge.
Okay. Now, I'm going to go a little bit in a different direction here because I'm interested in a program that you're doing at Northwestern University. And so I guess one of my questions would be, you've already been there for a period of time. Has there been something that you learned there that was just like one of those wow moments? Like, wow, I didn't know that. I would suspect that, anytime you get into a center that has a center of excellence that has a very specific focus, they're always going to have cool little things that you never thought of.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBARRETT at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
Yes. The one thing is biomechanics.
Okay.
I do, and I know the biomechanics of, yes, right. Bio is, I can pretty much familiar with the biomechanics of foot and ankle, but before then, I need to more understand about the mechanics.
Right.
Yeah.
Tell me one thing that has changed, maybe some of your perceptions that you've learned at Northwestern already.
And yeah, about the mechanics, I have to learn about for my last year, for the 2 semester, for 6 months, I have to learn about the torque, moment. Before we are getting in touch with the bio, we have to force and weight, and how to do it will affect our motion. How to handle the correction of the foot orthotics or ankle foot orthotics. to get better my patients. About the theory, I've learned, and I can do more confidently do practice with biomechanics to my patients.
Okay. Let me ask you a question about equines. Because
Equines?
yes. It's incredible. So as you know, I specialize in lower extremity peripheral nerve. So that's about 99% of all that I've been doing for the last 10 years or more. But it's pretty incredible to me how many people have some disastrous forefoot surgery and no one has ever looked to see if that patient has equines. And I think it's like putting a new tire on a car that's badly out of a line, that it's not going, most of the time these things don't work real well because they never address this component of equitis in the biomechanics of that particular patient.
Mm-hmm. That is interesting, right? We are always, every time we are focused past planus, not the equinus, right?
Right. But it's pretty hard to have pes planus without equines.
Mm-hmm.
Right?
Yes, right.
Yeah, right. So that's why I think that, sometimes surgeons will get very pigeonholed into what they're looking at. But let's say if the problem is here, and something's up here that's causing this, if you don't take care of this one doesn't ever get better no matter what you do to it, right?
Yes. That is one of I'm learning from the biomechanics of New Parks, Northwestern University, prosthetic center. Because I can now, if I have a chance, I probably can translate the function and understand the other persons to do that. Because sometimes the physician, the surgeons cannot understand what I am talking about.
Right. That's because the surgeons are knuckleheads like myself. And we need to be, schooled by people who really know things like you.
It is my great honor because, I would like to just do it. This is right. Or just it is comes from the textbook. You have to do that. I do not like this one because people do not want to accept what they didn't experience. To change their mind, I have to do something more solid based with the theory, not just for experience. But on that point, I think this class is really important for me. And sometimes I can see the class with different perspective because I have pretty much experience about this field already. So it is so interesting.
It is. And so the more you learn that there's that much more to learn.
Sure. Yeah. You know that already.
And I think sometimes the more you learn, the more confused you become.
Right. Because that is the power to make me learn more hard and push me more devote to this field. Because I try to see as many as patients possible in Korea, South Korea, from 8 a.m. to the 8 p.m. because there are so many patients in there in South Korea with foot and ankle problems. But now I know that the patients want to see the doctors who are pretty good at the biomechanics and podiatric medicine.
Okay.
So if
No, go ahead.
Yeah, if there is a chance, I think we have some association from the States and the Korea. And if you doctors and podiatric medicine doctors will have some lectures or show us that what the podiatry is and what it is good for the patients. I think it is pretty much helpful for the doctors in Korea, because we don't have any curriculum or any schools like that. There is just for the medical students and dentists and oriental medicine, just the 3 parts of the medicine in there in Korea.
So I'm going to jump to a question that I think is kind of interesting, because I think the perspective that you have coming from South Korea and spending so much time here in the United States, you've got this beautiful opportunity to blend these two knowledge bases together and actually get something that very few people can get, because they don't have the luxury of having the experience in one country versus another country. It's just they get into their little rut in their country, and that's, so you can learn so many things from the other perspective. So with all of that, that's a very long-winded explanation to, I guess, the question I'm going to ask you. But what's made the most prominent thing that you learned in the U.S. that you're taking back to South Korea from this standpoint? And then what's the one thing that people just take and understand in South Korea so well, but nobody here in the U.S. knows about? What are those two things?
This is a global world, so everything is sharing about that. I know that, but the most important, the specific thing, I just stayed here just 2 months. So as I can say right now is in Korea, there is so many doctors devoted to coalitions, because I am a physical medicine rehabilitation physician, right, and I can handle foot and lower extremity and spine and cervical. I can do all.
Right.
So I have some perspective, even though I have some mandibular, I can see the torticollis with the pars planus patients. Mm-hmm. But here, it is very good system, but we have some obligation. If just in case I am a orthotist, I can handle just the foot orthotics, and I can do not prescribe the ankle foot orthosis. You already know that, right?
No, I didn't know that. I did not.
Oh, so we have some obligation. We cannot over the probably gastrocnemius level. Okay. We can do the supramalleolar orthosis and the foot orthotics as an orthotist in United States. But in Korea, I'm a physical medicine physician. There is no podiatric medicine in there, but I can prescribe the AFO and knee ankle foot orthosis and spinal orthosis and sometimes cervical orthosis.
Right.
And I can care for that patient. So that's why I can very good at the lower extremity biomechanics, can make the spinal scoliosis. I can stand. I did so many patients. I did see so many patients have that problem. I can definitely tell the other doctors the lower extremity problem and pars planus can tremendously affect the spinal scoliosis. But if I have to see the only foot, I have to only see the spine, right? How I know that it is correlated?
Well, that was my point earlier, that
we tend to get so focused on these little particular areas of our expertise that we don't recognize close other things that are affecting what we're really doing. And that's why I make the analogy to the car that is out of alignment. It doesn't make any sense to keep putting new tires on it until you get the car back into alignment. So I think that's very, very important with what you just said, is that you have a more global perspective because of your training in PMN&R and what you were doing in Korea. Now you're integrating this other, and that's a great thing because it gives you the ability to really see more what's going on than somebody who's just is that fair?
Yeah, exactly right. On the contrary, in here, I really love to learn the focusing on one part because it makes me very exactly knows what it is.
Right.
If you have to learn, if you have to care for the patients from top to the bottom, sometimes it is not as much precise or as much high level. You cannot go this level. But here, I can learn from the school as a physical examination. It is very important because if the physical examination is not correct, I cannot the data as a reference, or I cannot use the data what I examine on the clinic. I would not use them as a journal or article.
Understood. So one thing that and this is a little bit tangential, but I'm going to pretend we're having a glass of wine and we're just talking about all kinds of things. But one of the things that we've become very interested here in the United States about 2 years ago is hydrodissection for peripheral nerve issues and entrapment. And when you start looking at the literature, and this is kind of brand new stuff here, but if you look at the literature, it's been done for more than 30 years in South Korea. So it's nothing new at all. It's kind of interesting how something could be 30 years old in one country and brand new in another.
Oh, really?
Yeah. I don't know. Are you guys involved with much hydrodissection over there in South Korea?
Hmm?
That like with D5W, the hydrodissections and that, are you doing any of that?
Oh, I have no idea about that because I am very familiar with what you when you taught us on 2010.
Right.
Yeah.
So
endoscopy.
Yeah, the endoscopic is one. But what I was going to say is that if you look in the literature, there is a fair amount of peer-reviewed literature coming from South Korea, and some of it's 30 years ago. And so it's not brand new, but the ability to put D5W around a nerve and get the benefits of that. And in Europe, they're starting to call it glucopuncture now. I did an episode a while back with Jan Kershaw, who is one of the leaders in this worldwide. He's from Belgium. But I was interested to ask you this question because it seems like really the majority of work is coming from South Korea. And I wanted to see if you had any experience with that or knew people who were doing it.
Oh, well, there is I don't have that experience because in Korea there has been a steady interest in podiatry medicine, but there are groups of orthopedic surgeons who do foot and ankle surgery.
Right.
And there are another society of non-surgical physicians. So I don't know the orthopedic surgeons have what kind of perspective about that. So but they are very active to write journals and articles. So I know that their society is growing very big and very fast.
Right.
So probably you would have some opportunity to see that kind of journals. Yeah.
Yeah. Well, I've got one more question. Well, I got two more questions that I want to ask you. One is diabetes, type 2 diabetes, a big problem in South Korea now, or is it pretty much non-existent compared to here?
Oh, it is problem. Yeah, there is a big problem that type 2 diabetes. So we have a diabetic society also. There are many doctors on there, in internal medicine and surgeon and other ear surgery doctors. And they are all engaged on the field of diabetic problems. So they is very active. And yes, we have a society, and it is growing problem in Korea, definitely.
Okay. And then I guess my last question to you is, what is the one thing that you really want to start research on now? What your interest is?
My interest?
Yeah. What will be the next research project you start after your experience at Northwest? What's going to be the next thing? Because you published so much already.
Well, frankly speaking, when I come before I come to here in Chicago, my catchphrase is idiopathic scoliosis is not idiopathic.
It's just that there's a bunch of idiots that are telling you that,
Mm-hmm.
right?
Yeah, idiopathic. Yeah,
idiopathic because you're an idiot.
Idiopathic. I cannot say. I would not call it just idiot. Idiopathic means we, as a physician, we did not figure out what is the problem. And I know I have pretty much experience about that. It is correlated with the biomechanics of the lower extremity, especially in of the podiatry medicine. So idiopathic scoliosis is not idiopathic. That is one of mine. And the other was early diagnosis of delayed development pediatric patients, including foot deformities, because the foot is very important to do on the normal motor development, the gait.
Right. Well, I think the point. I think the point you make about idiopathic scoliosis is very similar to the point that I try to make when people tell me that they have idiopathic neuropathy. And that's why I use the term idiots, because a lot of times people don't want to look hard enough to figure out what's really causing this patient to have neuropathy. And so they just label it idiopathic because they don't want to do a lot of work. But, if you look at the literature, idiopathic neuropathy is estimated as high as 50% of all neuropathies, which I think is totally wrong. I think of that 50% number, probably if you really did your homework and really figured out what was going on with the patient, it's a much smaller percentage than that. Because like you pointed out in scoliosis, if you have something going on with the lower extremity, like as splenus, it's going to affect the spine. But people aren't looking at it that way, so they label it idiopathic, right?
Yeah. And may I ask, is there any idiopathic neuropathy is over the 50% here?
It depends on what you look at from a literature search. But if you look, if you just put in a literature search and pull a couple of articles, you'll find that idiopathic neuropathy is estimated as high as 50% of all neuropathic cases, which is nonsense. There's no way that 50% of all neuropathy has no reason. It just means that the clinicians haven't worked hard enough to figure out what that reason really is.
Wow. If the neuropathy is, if as a physician, if you diagnose your patient's neuropathy is idiopathic, how do you care for your patient?
You can't, because you can only treat the symptoms maybe and not figure out what's really causing it, correct?
Oh, I probably, if my patients is 50% of my patients may be idiopathic, I I cannot run the clinic because my clinic is the final destination of my hospital because every doctor who do not know what is the factor or what is the diagnosis let their patients come to me. So that's why my clinic is very famous. Yeah. So every doctor, pediatrics and internal medicine doctors, every doctor who do not know, just they know the symptoms and they cannot figure out what it is, and they will ask me and what it is. So idiopathic make the doctors very hard and make them crazy.
Right. Well, I think that a lot of people get labeled as patients, and then once that label is on them, they're stuck with the rest of that label. They're stuck with the rest of their life. That was my point about, it's a lot easier to call something idiopathic than to actually try to figure out what the hell's really going on with these patients. So I think there might be a component of, I think there's several components. I mean, that's probably best for another time of discussion, but I just think that's interesting that you pointed out in scoliosis that a lot of those cases where they label it as idiopathic scoliosis, there's a definitive reason of why they have that, and you're able to tell them that.
Yeah. And before I knew that there is many patients who transform from the functional, and then there is a structural disability come out. Before then, I can see the patients who can handle, if we can handle them, it is good to the therapy for the scoliosis, I think. And it's the same as the neuropathy. And may I have a question about the neuropathy?
Sure.
Yeah, I've been watching TV drama. Is Dr. Hauser. He is very good at to diagnose the rare disease. Mm-hmm. I remember. Yeah, is there any department in states like that drama, which is very concentrated to diagnosis for the rare disease?
Yes, I think that, there are quite a few university-based systems throughout the United States. Actually, Northwestern has some pretty good peripheral nerve surgeons up there. Johns Hopkins, trying to think, Mayo Clinic. There's a lot of Stanford. There's a lot of very super specialized neuropathic, what you call rare diseases, those types of things that are very, very good. The inherent problem in some of that is that, again, when you talk about, you get so specific and so focused and so dialed in on something like small, sometimes they don't recognize what's going on from a big standpoint, and that's why, sometimes it still slides under the radar as idiopathic when in fact a lot of times it's not, and they just haven't looked at something else. So, but to answer your question, there are some of those centers, and there are some cases that they could never find a reason for. That's true. And they've run lab panels and MRIs and different types of imaging and all of the things, anything you can think of, and they still can't find a reason. But my point was earlier is that out of all of the cases that are given a label of idiopathic neuropathy, the majority of those idiopathic labels are wrong. There is something that can be found that's causing that patient's problem. That was the only thing that I was, trying to contend. But this is great. Been a great discussion. I can't tell you how happy I am to revisit things with you. It's been a long time, and I hope that it's not so long before we chat again to have the next conversation. So thank you so much, Soyoung, for coming on, and you're an inspiration to many of us.
It was great pleasure and my honor for seeing you again.
And we'll have to work on some research projects in the future.
Sure, I will.
Okay. All right. Have a great day. Thanks so much for coming on. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at SavantCellars.com. That is CEVANT Cellars.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.